Hello, everyone. Welcome to this industry-sponsored symposium. Today, we'll be talking about advancements in biomarker-driven care for gynecologic malignancies, and our speaker will be Dr. Deborah Richardson. I will remind you that, and I would love for you guys to complete the surveys that are at your table, so hard copies that are there. We're also going to do some audience response questions during this time. So there's actually a QR code, so you can use your smart device, scan it, and you'll be able to answer some questions for some additional interactivity during this session. So I'd love to introduce you to Dr. Richardson. She probably needs no introduction, but Dr. Richardson is an associate professor of obstetrics and gynecologic oncology and is the section chief for gynecologic oncology, at the Stevenson Cancer Center at the University of Oklahoma Health Sciences Center. She's a clinician, she's a surgeon, and also a clinical trialist. She spends about 50% of her time leading phase 1 clinical trials with the Stevenson Cancer Center Early Phase Drug Development Unit. And she's a GOG Foundation Scholar, a member of the GOG Partner Investigator Council. And she's really involved in NRG oncology. She's a member of the Ovarian Committee, the Developmental Therapeutic Committee, and the chair of the Early Phase Trial Oversight Committee. She completed her residency at the University of Connecticut, her gynecologic oncology fellowship at the Ohio State University, and she was faculty at UT Southwestern for 8 years. She was the PI of GOG 186J and is currently the national PI of GOG 3048, which is known as Uplift, and the international PI of GOG 3049, Up Next. In addition to all of her clinical activities, Dr. Richardson also enjoys doing medical missions. She has completed one in the Philippines and also in Nigeria. So we're thrilled to have her as our speaker today, and let's welcome her to the stage.
Thank you very much for that introduction, and thanks to GSK for sponsoring this event, and also to the WAGO staff for helping to organize. And I'm really excited to talk to you guys today. Of course, Katie Moore is a really hard person to follow for a talk. Luckily, she is my partner, but she kind of teed this up. So this is our agenda. I'm not going to read it to you. And these are our objectives. We're going to review up-to-date advances in biomarker-driven management of patients with ovarian or endometrial cancer and implications for outcomes. And isn't it exciting that we can talk about biomarker-driven treatments? Because for a long time, we really didn't have that in GYN malignancies. We really lagged behind some of the other solid tumors. We're going to discuss how currently actionable biomarkers impact treatment selection for these diseases. And then we're going to consider where are we going in the future. So I think everybody in the room is probably familiar with this, but globally there's over 300,000 cases of ovary diagnosed a year, and over 200,000 women lose their lives to this disease. And in the US, we estimate in 2023 there'll be almost 20,000 new diagnoses and over 13,000 deaths. We know it is currently the deadliest GYN cancer, though I'm going to show you some stats on uterine cancer, and uterine cancer is going to surpass ovary cancer very soon, which when I was a fellow, to put it into perspective, makes me feel old. But uterine cancer wasn't even the top 10 causes of death in women in the United States when I was a fellow, and now it's going to surpass ovary. It is the 5th most common cancer-related death among women, and we do know that there are some disparities, that there are higher mortality rates among African-American women than for Caucasian women. And so ovarian cancer, I don't need to really tell you guys, but you're aware. There's different types of ovary cancer, and so when people are reading about ovary cancer, mostly what we're talking about is high-grade serous ovary cancer, but that kind of leaves out all the other ones, and they're important as well. We have low-grade serous, we have clear cell, mucinous, et cetera. And these can predict prognosis. It also is correlated a lot of times with stage. We know that BRCA1 and 2 mutations are important, but there's also homologous recombination deficiency. We also know that these tumors are not very favorable environment in the tumor microenvironment for immunotherapy. which is probably why we have not had a lot of success yet with the immunotherapy, at least checkpoints that we've tried. So that's still an area of active research. And so really, what was our first biomarker for ovary cancer or BRCA mutations? And in 2011, bevacizumab was introduced because of multiple trials, including GOG-218 and ICON-7, and with an improvement in PFS of about 4 months, but did not really translate into an overall survival benefit. We were still treating all patients kind of similarly, irregardless of what their histology was, and no biologic markers. And in 2005, PARP inhibitors entered clinical trials in patients with BRCA mutated ovarian cancer. And first, obviously, PARP inhibitors read out in recurrent disease, so that was in the 2012. And then you go towards the right-hand side of the slide, and Katie Moore presented Solo 1 at ESMO in 2018, and that was one of the most impressive curves we've ever seen, with an amazing hazard ratio that really then moved PARP inhibitor maintenance up to the front line for BRCA mutation patients. And then we have additional trials now, including Prima Paula and Athena Mono, kind of showing the benefit of PARP inhibitor maintenance after frontline therapy. So not all ovary cancers are the same, and we kind of have to become, I can remember Miller telling me, well, are you a lumper or a splitter? I think it's time to split. I think the data is there that we shouldn't be treating all these patients the same. So we know clear cell can be funny because a lot of times it's early stage, but when it's late stage, it's pretty aggressive and doesn't really respond to chemotherapy very well. But we do really need the molecular characteristics of these diseases to best plan treatment for them. And so, for example, in our type 1, we know that there's genetic stability typically, and some of the mutated genes that can be commonly seen are P10. We can see KRAS mutations, which Dr. Moore just showed us a trial that's being done to target that. We have CTNNB1 or beta-catenin, and then PIK3CAs. And on our type 2, we know that pretty much universally, if you have high-grade serous ovary cancer, you have a problem with P53. But there are also CCNE1 mutations that are common as well. And then obviously these are BRCA1 and BRCA2 mutations. Now this is the uterine corpus cancer statistics. So you can see globally over 400,000 cases in 2020, of which 65,000 were in the US, and then it breaks it down by subtype. I'm not gonna tell you anything you don't know. Endometrioid by far is the most common. You can see that the serous is in the light blue color, 8,000. And if you go to the right side, you can see serous cancers account for the majority of the deaths in uterine cancer, about 4,000. So it is the highest category. We know it's the most lethal subtype. And then in this grouping, sarcoma and carcinosarcoma are grouped together. It's from SEER data, and that's how they put it together. But we all know that carcinosarcoma is really a poorly differentiated adenocarcinoma rather than a sarcoma. But we have some work to do for some of these high-risk histologies. And unfortunately, uterine cancer mortality is rising. It's one of the few cancers actually in the US where we're going in the wrong direction, and we really need to make some changes, I think. So at the top left is endometrial cancer. The blue is the rate of diagnoses, and the orange is death. And below that is ovarian cancer, to the right is cervix cancer, and you can see that endometrial cancer increased 19% over the 10-year period from 2009 to 2019. Ovary cancer actually went down 24%, and we heard from one of our presenters this morning, part of that may be because, a fallopian tube, although a lot of times when people are looking at statistics for ovary cancer, they are actually including fallopian tube and primary peritoneal in those numbers. And there's probably some other reasons that that's dropping. Perhaps opportunistic salpingectomy. That's my hope anyway. And then cervix cancer, pretty flat, 2.3, 2.2, which this talk is really not about cervix cancer, but we also heard a couple of nice talks earlier about cervical cancer. And the truth is, no woman in the United States needs to die from cervix cancer. So until we get to zero, our work is not going to be finished for that either. So we know people with advanced or recurrent uterine cancer don't do very well. The median age of diagnosis is about 63, and once you fail frontline chemotherapy for uterine cancer, the average survival is less than a year. About 13% of uterine cancers recur, And endometrial cancer has the highest rate of DMMR and MSI high of all solid tumors, which is actually really great, especially after our recent presentations at SGO and ASCO. So I'm going to make the case also that all uterine cancer is not the same either. I mean, I think everybody knows that also and has known that for a long time, but we've moved on from the type 1, type 2 now to a little bit more sophisticated. So obviously we can break it down by histologic subtypes. We can break it down by grade, whether or not there's LVSI, and that's really the uterine cancer staging system. The new one is really complicated, but LVSI is going to play a more prominent role in the staging system, and then depth of myometrial invasion. For molecular, we know polymutation status is important, mismatch repair status is important, MSI, whether or not they have P53 mutations, and then whether or not they have hormonal expression or not. And then there are some clinical factors and then some blood-based biomarkers. And you'll see circulating tumor cells and circulating tumor DNA. That's not really quite prime time yet. You can certainly order these tests, but we don't have a lot of data yet in uterine cancer, but that data will be coming. So some of the blood-based biomarkers are really more exploratory and coming in the future. And FDA recognized diagnostics do play an important role in personalized treatment. On the left is what a CDX is, so that's a companion diagnostic, and that's a medical device that provides information that is essential for the safe or effective use of a specific drug or biologic product. The CDX must be used to prescribe a therapy on label, and there are multiple examples of this. And then on the right is a complementary diagnostic, which is a test that aids in clinically meaningful benefit risk decision making about the use of a specific therapeutic product. While information about a complementary in vitro device is included in the therapeutic profile labeling, it is optional. So CDX immunohistochemistry assays are characterized by different platforms, different scorings, different thresholds. So on the left is H-score, in the middle PS2+, and on the right is tumor proportions score. So H-score shows both the staining intensity and percentage of cells. Then PS2 is the intensity and proportion of positive cells with moderate and strong staining. So for example, the antibody drug conjugate that targets folate that was recently FDA approved uses the PS2 scoring system. On the right, you'll see the TPS, which is the percentage of viable stained cells of any intensity relative to the total number of viable cells in the sample. And there's another antibody drug conjugate that's currently under development that's using that scoring system. So it just has to be validated for the drug that you're using. So it will not be the same for every drug. And we have to kind of familiarize ourselves with what are the tests that are being done in order to help determine treatment. And then there is the combined positive score, which Dr. Moore mentioned earlier. That's how we decide whether or not we can use immunotherapy with chemo for cervix cancer. And so that takes the number of PD-L1 positive tumor cells, divides it by the total number of viable tumor cells, and then multiplies it by 100. So please scan the QR code to join if you haven't already. Give you guys a second, because these are our audience response questions. I think it may also be on your table if you're having any trouble with getting it from up there. Okay, so I'm going to start the poll. How is your level of understanding of biomarkers and impact on outcomes for patients with ovarian and endometrial cancer? So A is low, B is medium, and C is high. Okay, it's kind of a nice split. Hopefully I can move some of you down the graph. Is NGS a tool adopted in your institution? And in case there's anybody in the room that doesn't know what NGS stands for, next generation sequencing. Okay, well, 97%, that's about what I would have guessed. Do you use the PROMIS algorithm for molecular classification of endometrial cancer? And if you don't know what it means, don't worry, we're going to talk about it. So it looks like about 20% of people so far, maybe a little 25, so a quarter, are using PROMIS, and most aren't. And I'm going to guess that the barrier is the POLE testing, and we'll talk about that. So what have we learned? What are our major milestones? I like this graph. It's kind of busy. But if you look, on the left hand, it starts off in 1985, and then it gets to the present day. And you can see there's not a whole lot on the left side of the graph before 2000. So we have, C125 becoming a marker in 1985. In 1995, we recognized that BRCA mutations increase the risk of breast and ovary cancer. It was localized to chromosome 17 and then able to be sequenced. Anti-angiogenesis then started to make its way, and on the top, by the way, is ovary cancer milestones, and on the bottom is uterine cancer milestones. But you can see, really, we don't start to get to kind of directed biomarker therapy till after 2010. So, what was really probably important in that was the TCGA. And so ovary actually reported it out first, then uterine, and that was the Cancer Genome Atlas, and that became really important for us to know, okay, these are important mutations in these cancers. This is where we need to start thinking about how these subtypes might be able to be targeted better. And then we had our first anti-PD-1 approved for all comers. Didn't matter where. It was the first the first directed therapy that was not based on where your tumor started, was agnostic. And we also had the PROMIS molecular characterization. And then as we get over to the right, we see that we get an approval of an ADC, the first ADC in ovary cancer. It was not the first ADC in GYN cancer. That would be an ADC in cervix cancer, which targets tissue factor. And then we go over to the right to the future, right? So there's a whole bunch of targets currently being investigated. So Dr. Moore alluded to some of these, but the WEE1, there's GAS6, there's PIK3 AKT, IL-2. So we're going to talk about ovary cancer in a little bit more depth. So the NCI launched the Cancer Genome Atlas in 2005. And, I think it's no surprise to any of us that in blue is the BRCA1 and 2 mutation patients, and they do the best. But interestingly, if you have a BRCA1 methylation, that's orange. They do actually the worst. They do a little bit worse than the BRCA wild type, which is in purple. So we know that if you BRCA1 epigenetic silence, they don't do as well, and they're not the same as a germline mutation. And we know that about 25% of newly diagnosed ovarian cancers harbor BRCA1, 2, at least if you're talking about high-grade serous, high-grade endometrioid. And the majority of those are germline, about 18%, and the rest are in tumor. And in addition, there's another 25% that are going to have homologous recombination deficiency not due to a BRCA1 or 2 mutation. And tumor testing is going to detect additional BRCA patients. And this was our first biomarker-led therapy for ovarian cancer, so this is the results from SOLO-1. The top line are the patients that got the PARP inhibitor. The orange line is the placebo. Again, you can drive a truck through those curves. When those curves were put up at ESMO, people gasped because we had never seen anything quite this good as far as hazard ratio and improvement in progression-free survival. And this data has now been updated to 7 years, still shows a benefit. The median progression-free survival in the control group was 13.8 months, which I think we were a little surprised maybe that BRCA patients recurred that early, because we all know that they live longer, but they actually recur fairly early. 13 months is not that long, it's just a little over a year. And it was not reached in the PARP arm. And hopefully we'll see some overall survival maturity in the next 2 years or so. And then endometrial cancer. So for decades, this really was considered one disease. In 1983, we first started thinking about this as type 1 versus type 2, low risk versus high risk. Then in 1997, we started to get a little bit more sophisticated. We know that endometrioid tend to be ER and PR positive. They're typically P53 negative. They're low proliferative index, and 25 to 30% are going to be MSI high. For serous, we know that most of them are going to be ER/PR low, but they're going to have p53 mutations, and they also have HER2, which is really important, especially in this new era of ADCs that target HER2. They are highly proliferative index, and they're typically microsatellite stable. For clear cell, they don't fit as well into a category. They can have different things, actually. But sometimes they have p53 mutations, sometimes they don't. They are typically hormone negative, receptor negative. And then carcinosarcoma is another one that really can express HER2. So remember HER2, especially for serous and for carcinosarc. And then that brings us to the PIK3 kinase AKT pathway alterations. These are fairly common in uterine cancer, so up to 30% of endometrial cancers can have activation in this pathway of the PI3 kinase AKT. These can be K3CA or AKT mutations or amplifications. There can be in up to 55% of endometrial cancer PTEN loss. They tend to be highly complex, so they'll have things that are both PTEN plus PIK3 kinase plus PIK3R1, KRAS, et cetera. So there can be multiple aberrations, and sometimes one drug might target one of those, but then actually the other mutation is going to make that drug not work. So we're going to have to get sophisticated when it comes to looking at it. It's not just, oh, you have a PTEN, I can give you this drug. It's actually quite a bit more complicated depending on what mutations go with what. Endometrial cancer has about 10% FGFR mutations, and that's important because there are some FGFR inhibitors under development, and there are also drugs being developed to target these pathways. But we do know that PIK3 kinase AKT mTOR pathway is a driver of treatment resistance, and that the activation inhibits platinum taxane-mediated apoptosis. So if you have somebody who's platinum resistant, this may be why, whatever that means in uterine cancer. It's not as well defined as it is in ovary cancer, but it's something to think about. So in 2013, again, you're probably all familiar with the 4 different subtypes of classification for uterine cancer from the TCGA. So we know that POLE is at the top. They're ultramutated. They are the lowest group of this 4, but they have the best prognosis. You have 100% survival. That's for low stage. Then we have like 2 intermediate groups. You have the MSI hypermutated, which accounts for about 39%, and then the most common is actually going to be your copy number low endometrioid, 49%, and you can see them in the middle. The MSI hypermutated is in the orange, purple is the endometrioid copy number low, and then serous-like is about 10%, and they do the worst. And chemotherapy is not sufficient for this group. This is an area where we need to improve. This is also an area where they may have HER2. So for uterine cancer, we're a little farther along maybe than we are in ovary cancer as far as the molecular pathways are concerned. So again, POLE are going to be ultramutated. They're going to have more than 100 mutations per megabyte. So it is important when you're looking at an NGS result that you're seeing that they are hypermutated, ultramutated. Because sometimes you get a POLE mutation, but it does not lead to ultramutation. So then they're not going to have the prognosis that the POLE mutated, ultramutated have. Then you've got your DMMR, which is going to have 10 to 100 mutations per megabyte, and then very low mutations on the right side of the graph. And you'll notice that some things are kind of similar between maybe 3 out of the 4 different subtypes. So for example, PTEN is present in all 4, but at a very high rate for POLE mutated, for DMMR, and for P53 wild type, and pretty low for the P53 abnormal copy number high group. Whereas P53, the only place that really shows up is in the P53 abnormal, which is what it what defines that group. And so POLE is, again, excellent prognosis. DMMR and P53 wild type, copy number low, or no specific molecular phenotype is how it's often referred to, intermediate. And then if you have P53 abnormal, poor prognosis. So this is the PROMISE tool for classification of endometrial cancer. And so what we would do is have your endometrial sample and then stain it for the 4 mismatch repair proteins, so MLH1, MSH2, MSH6, PMS2. And if they were deficient, then you're done. If they were intact, then you go on to do POLE testing. And I think this is maybe why a lot of people said they don't use this test yet in classification in their institutions, because At many institutions, the only way to get this is to order next-generation sequencing, and the problem is it's hard to get next-generation sequencing on a stage 1 or a stage 2. You can easily justify a metastatic uterine cancer. You can even, usually justify it for a stage 3 potentially, but it's much harder to justify currently, although hopefully that'll change as the guidelines are changing and we're moving to this. And poly might be an area where we can decrease treatment. Maybe we're over-treating these patients. Then if they're poly wild type, then you go to the next thing, which is P53. And they're either then P53 wild type or P53 abnormal. And so that's the PROMISE tool. But next generation sequencing does provide opportunity for targeted therapies. And these are just a list of commercially available tests that probably all of you have used at least one of these in the past, and most people have their kind of go-to one. But it's good to kind of know what is the differences between the different tests out there, and what are they testing, how many genes. So you can see HRD you can get from Foundation Care's Tempus. You can get MSI from all of them, you can get TMB from all of them, and you can get PDL1 from Foundation Care's Tempus Foundation 1 Liquid CDX. So what do we do now that we have this knowledge? How can we apply this to patient care? So we have multiple studies, again, we've already kind of discussed this, that angiogenesis is a target for treatment for ovarian cancer, and that we know that bevacizumab improved the progression-free survival, but overall survival was not significant. And we gave chemotherapy plus or minus bevacizumab in the front line. We've done it in the platinum-sensitive recurrent ovary cancer and the platinum-resistant recurrent ovary cancer. Now, if you look at GOG 213, actually, when they reclassified, some of the patients had been kind of misclassified, and when they refixed what it had been stratified on, they did see a survival benefit to the Bev arm. So that is in the paper. But originally, it was presented as there was no benefit to bevacizumab as far as overall survival was concerned. You do get about a 4-month improvement in progression-free survival whenever you add Bev. So whether you give it frontline, whether you give it in platinum-sensitive recurrence, or you give it in platinum-resistant recurrence, you pretty much get the same bang for your buck. We also do have some data that you can use Bev after Bev, so that if you've used it in the front line, it's been shown that the resistance mechanisms to bevacizumab are very different than they are to chemotherapy, and that it can continue to be effective and potentially improve the response rates, for example, MPFS from chemo. So what are some common tested biomarkers that we use for ovarian cancer? On the left, we have our prognostic. We know that BRCA germline are prognostic. They're also predictive, right? So that these can help us determine should we use a PARP inhibitor or not. We know that if we give a PARP inhibitor to BRCA mutation patient, they're likely to do well. And that is true whether it's a germline or a somatic. We also have homologous recombination deficiency. There's MSI status, there's mismatch repair proteins, and then I moved folate receptor alpha here to predictive at this point, now that we have a drug approved for it. And then we do have some exploratory. We have the PIK3 kinase, and then TMB, unclear, even though there is a anti-PD-1 that is approved if you have a TMB that's high, which is greater than or equal to 10. Not really clear if it works very well for ovary cancer patients, but you can use it in that setting. I think there is definitely some confusion on which biomarker to use, especially when you're talking about HRD for ovary cancer. And as Dr. Moore brought up earlier, it is difficult to know definitely who's going to benefit from PARP or not from our current tests that we have available. And we have centralized testing for most of this. So different people in the room probably use different labs for it, and they do not all give you the exact same information. And they have different cutoffs of how they define HRD. But what we know is that basically PARP inhibitors seem to benefit all these different subgroups. So on the left is frontline maintenance trials, and you can see everything is on the left of the line. So if it was on the right, it would favor the placebo. On the left favors the PARP, and every box is on the left side of the line. It's just what is the magnitude of benefit. And we get the most bang for our buck with PARP inhibitor in frontline maintenance if you have a BRCA mutation. The next thing is HRD, and then you go to things like BRCA wild type, genomic instability negative, but LOH high, and then you go to BRCA wild type, genomic instability negative, LOH low. And then there's the BRCA wild type, HRD test not positive. And on the right is your relapse maintenance trials. These are farther to the left, right, of favoring PARP inhibitors. And that's because the biomarker here that's predicting response to PARP is platinum sensitivity, right? So all these patients had to have platinum sensitive recurrence. They were then retreated with platinum. They had to have a CR or a PR, and that then predicts them doing well with PARP maintenance. So here is like kind of a schematic of HRD on the right, and then what is called HRP, but really it should be HRD test negative, because we don't really know if they're proficient HR or not. But you can see bevacizumab can be used in all of these patients. PARP inhibitors can be used in all of these patients. And then for upfront maintenance anyway, we have a PARP inhibitor combined with bevacizumab that's FDA approved if you're HRD test positive. And this is kind of a treatment algorithm. So the idea of using bevacizumab and PARP inhibitor, you might divorce those when you make those decisions, right? So first you have a newly diagnosed ovarian cancer patient. And you're going to do germline testing, hopefully at the new diagnosis on that patient. And then if they're BRCA wild type, you're going to order tumor testing. And you're going to decide whether you're not going to give neoadjuvant chemotherapy, or you're going to do surgery first and then give chemotherapy, which is going to be platinum taxane. Then you're going to decide whether or not you're going to give bevacizumab to the patient. So if you did not give bevacizumab to your patient with the chemotherapy, then your options for maintenance are PARP inhibitor if they're BRCA mutated or HRD. But you can also use a PARP inhibitor, or you could choose surveillance if they were HRD test not positive. If you gave bevacizumab during chemotherapy, then if they're BRCA mutated or HRD, then you can add the PARP inhibitor. And if they are HRD test not positive, then you're going to continue the bevacizumab as maintenance. And first-line treatment decisions can influence our second-line maintenance treatment choice, right? So if you've given previous PARP inhibitor, but they're Bev naive, then you can definitely give bevacizumab with the chemotherapy and then continue Bev as maintenance. Really unclear what the role of PARP inhibitor would be in this setting. We have minimal data about PARP after PARP. And I think a lot would come down to, is your patient BRCA mutated? Were they on or off the PARP when they recurred? What was their response to their second-line chemotherapy, et cetera? So there's a lot of unknowns in this space. Next would be previous Bev, but PARP naive. Then your second-line maintenance is likely going to be PARP inhibitor if they meet criteria, though you could use Bev again. But if it were me and I had a PARP naive patient and they met criteria, I would use the PARP. And then for bottom, if you've had both Bev and PARP, which can definitely happen now with frontline maintenance, what do? Well, you can reuse Bev. We do have data for that. Unclear if you can use PARP again. Would you give Bev PARP? Again, that trial was done in the frontline setting. We don't have data for that for the second line setting if you've already been previously exposed. Active surveillance. And then there are multiple trials ongoing right now that are phase 3 that are looking at antibody drug conjugates in this setting as maintenance. And so that brings me to this. So what are some emerging therapies that we have for platinum-resistant ovarian cancer? So we have antibody drug conjugates, and this is getting to be a busier space. So we do have now one FDA-approved folate receptor alpha ADC monotherapy, and as you heard from Dr. Moore, there's another one that's coming along in development that's getting ready for a phase 3 trial. There are actually several others in phase 1 trials, all with different linkers, all with different drugs. And this is where it's going to get really interesting, because we don't exactly understand all of the mechanisms of resistance to antibody drug conjugates, and so there's going to be a question: if you've had an ADC, can you get another ADC? I get questions a lot about how do you decide to sequence them. Say they're positive for 2 different proteins on their surface, and both drugs are approved. How are you going to decide, and what sequence would you give? Well, we don't know the answers to those yet, but it's probably going to come down to toxicity and patient preference and dosing, et cetera. But you can basically become resistant to an antibody drug conjugate in a lot of different ways. They can downregulate the receptor that you're trying to target from the surface, right? So if it's folate, well, then you wouldn't want to use another folate if the cell's no longer putting folate on its surface. But it can also be very complex. So when an antibody-drug conjugate gets taken up into the cell, it goes into the lysosome. Well, if there's some resistance there, then it would probably make you resistant to every type of antibody-drug conjugate if the cell is not going to lyse the chemotherapy tail off. So I feel like we have a lot to learn, actually, in this arena. And then we saw the nice data from Mirasol that Dr. Moore showed about folate receptor alpha antibody-drug conjugate versus investigator's choice chemotherapy with an OS benefit. There's also an NaPi2b based antibody-drug conjugate under development, and like I said, many others that are earlier in development. For immunotherapy, so everybody wants immunotherapy to work for ovary cancer. Hasn't really yet, but one idea is to try and change, like I said, the tumor microenvironment is very hostile in ovary cancer to the immune system working. And so one idea is to give an anti-PD-L1, give a PARP so that you get more antigen release, give a TKI because it changes the tumor microenvironment and perhaps makes it more likely to respond to IO, kind of like we have the combination of a multi-target kinase inhibitor and anti-PD-1 for uterine cancer if you're MS stable, right, in the recurrent setting, at least before we had frontline IO with chemo. Another way to think about it is to use a combination of IL-2 and anti-PD-1. So, and then there are many, many actually other things in immunotherapy being looked at right now for ovary cancer. And hopefully one of these is going to work someday. And then there's lots of things that are taxane-containing backbones. So we heard from Dr. Moore about the anti-angiogenic gene therapy and taxane plus placebo plus taxane that was presented at ASCO that was unfortunately did not meet its primary endpoint of PFS. And again, taxane had a, control arm had about a 30% response rate, even though they allowed up to 5 priors, which we had never allowed more than 3 priors before in a phase 3 like that. So that's pretty impressive that we can maintain activity. There are tumor treating fields plus taxane or taxane alone. And if you don't know what they are, they basically have to wear these little pads. And it's like a little backpack for like 22 out of 24 hours a day. And it actually is used in mesothelioma and for glioblastoma. So we'll get some results on that. It's a very different way, but it basically disrupts the microtubules. There's an AKT inhibitor plus taxane versus taxane, and then there's a recombinant fusion protein plus taxane versus placebo plus taxane. So everybody wants to take their drug and add it onto taxane and see if we can beat taxane alone. It's a common combination. And this was the SORAYA data that was presented at SGO last year by Dr. Matalonis that showed that the median duration of response for the investigator assessed for the antibody-drug conjugate that targeted folate was 6.9 months and not reached when it was by the blind and independent central review, which a lot of people argue, at least in a study like this, you might need BICR because you only have one arm and there could be some bias. But in a randomized placebo-blinded trial, I think a lot of people have made the argument, why are we still doing BICR? Because it pretty much every time you look, it's very similar to how the investigator called it. And we saw that treatment benefit was observed regardless of the number of prior lines of therapy and whether or not they had BRCA mutations. And so this is what led to the FDA accelerated approval that then got confirmed by the Mirasol that was just presented at ASCO. And now we're going back to endometrial cancer. So what are some current options for biomarker-directed therapy? So again, endometrial cancer has the highest rate of MSI high of all solid tumors. Endometrial cancer is in blue on the left, and next to it's colorectal cancer. And then if you look over towards the right, but still on the left half of it, you'll find ovary cancer. And that's under 2% or so of ovary cancer cases are MSI high. But you can see it's over 25% for uterine cancer. And again, based on both PROMIS and TransportTech classifiers, POLI, very important, MMR and MSI status, and then the P53. But there are others. So we have TMB. Some people use C125. We know that estrogen progesterone receptors can be important, beta-catenin pathway, BCL2. There are some tumor suppressor genes like P10 and P21. There's some oncogenes. Again, we have some targeted therapies under development for these oncogenes that are making them relevant. So we have drugs that target KRAS. We have drugs that target HER2, EGFR, PIK3 kinase, and FGFR2. Also, ARID1A, which is a really interesting thing because it has multiple different ways that it may interact with uterine cancer, and lots of pathways. So there may be some issues of ARID1A mutations and response to immunotherapy, for example. So we have a lot to learn actually about ARID1A and its play and importance in uterine cancer. And then I had talked to you about circulating tumor DNA. I think that circulating tumor DNA is going to become much more relevant. Currently, it's actually, there are several companion diagnostics that use circulating tumor DNA. It's actually approved for non-small lung cancer. They use it especially in early stage colorectal cancer. It can be used to determine whether or not to use a PIK3 kinase drug for breast cancer. It can be used to see whether or not you should use a PARP inhibitor for prostate cancer. And actually, there's one liquid biopsy for ovary cancer for a PARP inhibitor. But the role still is being refined for, I think, our cancers, but it's coming and we need to be ready. So we lagged for a long time when it came to sending tissue and next generation sequencing. When I was a new attending, I would send these tests and I would get the results. And after a while, I gave up because I would get this information and I didn't have any, they wouldn't have anything targetable, or they'd have something targetable, but I couldn't get the insurance companies to approve them, and we didn't really have a lot of drugs under development. And today, I basically use that information most weeks, if not most days, because it helps us determine what treatment to use. We've got FDA-directed therapies, but in addition, because I do drug development, I've got all sorts of trials that are targeting certain mutations. And that helps us prioritize what trial to offer a patient. And I don't know if any of you have been contacted yet by any of the companies, but some of the trials now, especially when they're looking for rare things, like for example TSC1 or 2, they're actually contacting you as a physician to say, hey, there's a trial. Your patient has this mutation, and there's a trial. And here's the closest open trial for you, for your patient. And so a lot of times if it's newly diagnosed, they're not going to be appropriate. But if they're recurrent, it may be worth the patient's time to travel to a center where they can get a clinical trial that goes to their mutations. So that's kind of all new and exciting. That's really happened recently. And we do know that both MMR status predicts our benefit of PD-1 inhibition, and also that there is a correlation in uterine cancer with TMB. So the SGO kind of took the promise but flipped it just a little bit. So basically, they do recommend that MMR testing by IHC is universally encouraged. In select circumstances, MLH1 promoter methylation may guide counseling and Lynch syndrome testing. We heard, from Dr. Moore about that MLH1 constitutive germline mutation. So it's a little bit unclear exactly what those guidelines are going to look like, but it is something to keep in mind that, it's not necessarily true that because you have MLH1 methylation that you don't have Lynch. And that we know that TMB high plus HER2 may provide rationale for selecting treatments, and that both P53 and POLE status are prognostic. So you'll see this is just a little bit different than the promise. So the promise started with DMMR testing or MMR testing. This actually starts with POLE. So that if you have a POLE mutation, you're done. If you don't, then you go to your MMR testing. Then you go to your P53 testing. And GOG86P was a 3-arm trial that looked at a couple of different regimens, and they found that when you took chemotherapy plus an anti-angiogenic agent in patients who were P53 abnormal, they actually might have done better. It was exploratory, but it's something to be aware of, to think maybe we should think about anti-angiogenic drugs in those patients, because clearly chemotherapy is not doing it alone. And then this is PD-1 and PD-L1 inhibitors in recurrent advanced DMMR and MSI high endometrial cancer. There's 2 different trials here, one drug on the left, one drug on the right. Again, you really can't compare the trials because they have different patient populations. The one on the right is the largest probably cohort that was shown in this group, but it was these are basically basket trials that then this is the uterine cancer patients out of them. But you can notice that the overall response rate is very similar. So on the left is 48%, on the right is 46%. These drugs clearly are active. This is single agent. This is not where we are today. But this was the very exciting 2 trials that were presented at SGO. So on the left, you'll see they're very similar, right, as far as our hazard ratio is concerned. So 0.28 to 0.3 on the left is Ruby, on the right is GY018. But essentially taking patients with metastatic or recurrent uterine cancer and adding PD-1 inhibitor to the chemotherapy plus maintenance versus just the chemotherapy plus placebo. There was a little bit difference in how long that maintenance was continued. So in Ruby, it was up to 3 years. In GY018, it was up to 20 cycles total of the PD-1. And they allowed up to 10 cycles of chemo. So that you have to kind of do the math. It's a little bit, they switched to after they went to maintenance, it was a 6-week maintenance. So it's about 2 years or so. So it's a little bit shorter in GY018, the maintenance is, than Ruby. And so this also makes me think about the circulating tumor DNA role, right? So patients are nervous about coming off of these drugs. I don't know about you, but I have a lot of patients that are like, I'm not coming off of this. I don't know what you're talking about. Like, great, I've had 2 years. I'm doing well. I'm going to stay on it. Well, there's cost, right? And they got to come to the infusion center. They may have out-of-pocket costs. They've got all sorts of stuff. They're missing work or they're missing their life. And so this is where I think ctDNA might offer a lot to us, where we could see if they were negative, would we feel comfortable stopping it? And how many negatives would you want? We don't know the answers to this, but these are the questions that I think about, where it might have a lot of benefit. Could it help us identify who needs to stay on the treatment, especially when we're talking about maintenance, and who could come off? We could apply the same thing to PARP inhibitors. If you're cured, you don't really need that PARP inhibitor for more than 2 years, and all we're doing is exposing your bone marrow to a drug that might have some toxicity. So it would be really great if we could get to a biomarker where we can say, you still have residual disease, we just can't detect it, we're going to keep you on maintenance, and you don't need it anymore. So I think that's where we hopefully will get to in the future. And then this was the PFS curves from the same 2 trials. So on the left is Ruby, on the right is GY018. Again, there was a PFS benefit. This is in the MMR proficient and the microsatellite stable group. And while it's not as impressive as the dMMR, it's still better than chemo alone. And let's not forget about hormonal therapy. It still has a role. Especially in those endometrial cancer, low grade, copy number low. So they're going to be likely to be microsatellite stable. So this is where you may want to think about hormonal therapy. And so this was a trial by Dr. Slomovitz, took an mTOR inhibitor with a aromatase inhibitor and compared it to SERM with progesterone. And you can see that the response rates were about the same. However, the progression-free survival is about double, 6.4 months versus 3.6 months in the combination of the mTOR aromatase inhibitor group. And the overall survival is a lot better in the mTOR aromatase inhibitor group, 31.3 months versus 16.6 months. Now, these are small numbers, right? There's less than 80 patients in this, but this is at least worth thinking about when you have a patient with advanced or recurrent endometrial cancer. And these drugs tend to be fairly well tolerated. And then anti-HER2 treatment with chemotherapy. So this was a trial of chemotherapy with or without a monoclonal antibody that targets HER2. And the median overall survival was 24.4 months in the control group versus 29.6 in the experimental group, and they noted the most benefit in the advanced patients, so stage 3 or 4 who had not had chemotherapy prior, because you were allowed to come on this if you had had previous 1 line of therapy in the adjuvant setting. So especially for patients who were treatment naive and were stage 3 or 4, they had an overall survival median of 25.4 months in the control group versus not reaching the experimental arm. And so this is when we added anti-HER2 therapy with chemo to the NCCN guidelines for HER2 new high uterine cancer. Now there are newer drugs that probably are more effective. So we don't exactly know what the HER2 expression in uterine serous carcinomas are. Dr. Moore kind of brought this up also, right? So we're extrapolating, like we're using scoring systems of gastric cancer or breast cancer, but mostly gastric, to determine 1+, 2+, 3+, right? And if they have a 1+, they're negative. If they have 3+, they're positive. If they have 2+, it has to be confirmed by either FISH or CISH. And we also know that HER2 can be overexpressed in uterine serous, carcinosarcoma as well, and perhaps also in clear cell. So it's worth looking for because you do have a target, and if they have HER2 positive, then these, there are drugs that help these patients do better. So it is definitely something you want to identify, and I do think we need a validated test for uterine cancer patients. It should also be noted that some people will use the NGS results, and that may work fine, especially if you're going to use an antibody-drug conjugate rather than the monoclonal antibody that's available right now as far as the results. But there's not as much concordance between NGS and ISH in uterine cancer as there is in breast cancer. So something to be aware of as far as interpreting the test results. So future developments, where are we going? We've talked about where we've been, now where are we going? Okay, so what are our most promising targets, right? So for one thing, we have all these clinical trials under development. Again, Dr. Moore kind of showed this, went over it in detail, but we know that for biomarker unselected, we've got the first trial that will hopefully read out sometime this year. We've got Nirvana 1 and AGO OVAR 28. And then for the BRCA mutated, and that's, by the way, in BRCA mutated, and then we have BRCA mutated LOH, Athena combo, right? And so what are the differences? So first is taking anti-PD-1, giving it with chemotherapy. And then you either get, and also Bev is up to the physician choice, and then you get maintenance. So everybody is getting PARP maintenance. If you are on Bev, then you continue on the Bev, and then the question is whether or not you get the anti-PD-1 or you get placebo. For Nirvana, it's chemotherapy plus an anti-VEGF, followed by PARP plus or minus Bev, versus chemotherapy, followed by PARP inhibitor. For Athena combo, it's PARP inhibitor with anti-PD-1. Then we've got HRD, so N plus is 3 cycles of chemotherapy versus 6 cycles of chemotherapy, followed by a PARP inhibitor. So can you give less chemo, start your maintenance earlier? That's kind of the question there. And then if you get to your non-BRCA mutated patients, Duo-O, which she went over in detail, so I don't really need to go over that with you other than like she pointed out, it's missing an arm. So it's a little hard to know what the role of the PD-1 is, added to the Bev PARP maintenance. And then we have the KeyLink 001 trial as well, which is an anti-PD-1 concurrent with chemotherapy, one continuation with or without PARP maintenance. So that takes the bevacizumab out. There are lots of drugs being developed for platinum-exposed ovarian cancer. So one biomarker is called NaPi2b. Uplift was a phase 2 trial that basically was embedded into the old phase 1 trial. So that middle trial is the phase 1 dose expansion. NaPi2b, the Uplift, was the phase 2. It was an international study. That data is expected later this year. And then up next, I will just say, so basically the drug is an antibody-drug conjugate that targets NaPi2b, which is a sodium phosphate transporter that's present on about 2/3 of high-grade serous ovary cancer. To put it in perspective, for folate receptor positive, it's about 1/3 of patients with high-grade serous are high folate receptor alpha. So it's a little bit higher with NaPi2b. In case you haven't heard and any of you have the trial open, up next was put on a partial clinical hold today by the FDA for some toxicity that they want to look into a little bit more. If patients are on it, they're allowed to remain on it if they are clinically benefiting, but no new patients are going to be enrolled at this time. And then Upgrade is a phase 1 dose escalation of the antibody-drug conjugate with different backbones, and currently the one that's being investigated is with platinum. So for future perspectives, developing the optimal HRD biomarker, we have lots of challenges. So the HRD assays currently are only really valid for the time point when the sample is obtained, right? So if you were chemo exposed and then you have the test done, it could be a scar. In other words, your tumor may no longer be homologous recombination deficient, but the test is going to be positive. So that is definitely a limitation to the current treatments. And liquid biopsies that sample circulating tumor cells, tumor DNA, or ascites may provide a more dynamic readout than current HRD assays, but that still remains to be determined. In addition, we have not really been able to identify who's not going to benefit from a PARP inhibitor, right? Like, it's clear that if you test positive for these tests that you're going to benefit from a PARP inhibitor likely. But we can't exactly eliminate who won't benefit, and that's really important because we know these drugs have side effects, and we certainly don't want to be harming people, and that's where that data was really interesting that Dr. Moore showed from ASCO, where if there are patients that we can identify that are not going to benefit from that therapy, we don't want to expose them. And so that is probably one of our bigger needs right now, is to try and develop a better biomarker that determines who will and won't benefit from PARP. So basically, the other thing is going to be when you have had a PARP and you progress on a PARP, or after you've had a PARP, understanding the resistance mechanisms. Right, so sometimes there's BRCA reversion mutations. Well, that's going to be a problem because that might make you not sensitive to platinum anymore. And so I think we have a lot to learn about what are the resistance mechanisms in the individual patient's tumor that are making them resistant to PARP, because that may help us figure out PARP combos or get away from PARP and do something else. So this is really an area of active research right now where biomarkers are going to be really important. And key targets and therapies under investigation for frontline endometrial cancer. So we've already seen Ruby Part 1 results, but Ruby Part 2 is not been resulted, and that's basically anti-PD-1 with chemotherapy, then anti-PD-1 plus a PARP maintenance versus chemotherapy, placebo, and placebo maintenance. There's LEAP-001, which is basically taking an anti-PD-1 plus a multi-target kinase inhibitor up front versus chemotherapy. So the question is, can you not give chemo at all? Now, this is going to be a little bit hard potentially to know where that's going to fit based on the results of Ruby and GY018, because now it looks like the new standard is chemotherapy with PD-1. And so if anti-PD-1 plus TKI is better than chemo, what does that mean? How much better does it need to be for us to say we're going to use that versus chemo with IO? I'm curious to see what this reads out. Another trial I like to think about is IO versus chemo IO in those DMMR MSI high. Do we need the chemo at all? It all remains to be seen. But that's what Keynote C93 is supposed to answer, as well as Domenica. And then there's all comers. So we heard already that Duo E is going to be presented later, that we did get a press release saying that it did meet its primary objective of improving progression-free survival and basically patients got anti-PD-L1 with chemo, followed by anti-PD-L1 with PARP maintenance, or they got anti-PD-1 plus chemotherapy, and then followed by anti-PD-1 with PARP placebo, basically. So these will be very interesting to see what, but they said basically both, I think, arms were positive. So we haven't seen the results, it's just the high-level data. And then there's also ATTEND, which we'll read out. And there are some ongoing studies of biomarker-directed therapy for endometrial cancer, and I think these are really cool studies. So EndoMap is basically an anti-PD-L1 in combination with an anti-VEGF if you don't have one of the mutations that they're looking for. But then if you have one of the mutations in your tumor that they're looking for, then you get directed biomarker therapy. And so that falls into the category of the PIK3 kinase AKT-P10 pathway. There's one for LOH. There's TDM1, which would be for HER2. There's also a treatment for MSI high and or TMB high for recurrent endometrial cancer in Bouquet. Again, all biomarker-driven therapy. I'm not going to read them all to you. You can see them, but all of these biomarkers that we were talking about, they have drugs now to target, and so the question is giving them targeted therapy for their mutation better than what we're doing now? And then Rainbow is looking at refining adjuvant therapy in uterine cancer based on molecular features. So the question is, for POLE, can we de-escalate? So in other words, no adjuvant treatment if you're stage 1 through 3 with a POLE mutant tumor. And For no specific molecular subtype, it's chemotherapy versus radiation therapy and hormonal therapy. For DMMR, it's radiation therapy versus radiation therapy with a PD-L1 inhibitor, and then P53 abnormal is chemo versus chemo with a DDR targeted agent. So I find this is actually really exciting, and we're gonna probably not treat everybody with uterine cancer the same way that we do today in a couple of years as these trials read out. And this is just to show TMB correlation with response to PD-1. So remember that the definition of high TMB is 10. So that's it's about halfway across the screen, maybe a little bit more than the right. And so ovary and uterine, for the most part, have low TMB. But if they have high above 10, you can consider it. But it's fairly low compared to these high tumors, for example, cutaneous squamous cell or colorectal. And these are molecules that are in phase 2 or 3 clinical trials. So I think it's really exciting that we have this much interest in biomarker-directed therapy. So we're just not treating everybody the same way anymore. So there's a bunch of molecules. And again, I'm not going to kind of read them all to you, but there are some pretty exciting things on this list, and they can be things that are targeting the tumor microenvironment. There are things that are targeting the behavior of the cancer. There are things that are trying to overcome resistance. And then on the right is your uterine cancer. And so for DMMR tumors, maybe adding tyrosine kinase inhibitors, again, the PIK3 kinase pathways, FGFR2 mutated tumors. If they're platinum sensitive or PALB2 mutated tumors, using a PARP inhibitor for uterine cancer. There's androgen receptor active therapy, so anti-hormone therapy. Again, PARP inhibitors for loss of heterozygosity high. So trying to really take somebody's tumor and then directing therapy. And common targets include estrogen receptor tumors, so there are SERDs, which are selective estrogen receptor degraders. These drugs are used for breast cancer, but we are investigating them now for uterine cancer and sometimes ovary cancer as well. There's also CDK4/6 inhibitors, again, borrowing from breast cancer, because they have dominated hormone therapy for a long time, because breast cancer tends to have ER/PR positive. And so we wonder, can we use some of these drugs that we use for breast cancer in our cancers? We've talked about antibody drug conjugates, and so there's all sorts of targets, including folate, TROP2 that we heard about, HER2. We talked about tumors with ARID1A loss, so ATR inhibitors may work in those patients. We've talked about WEE1 inhibitors for P53 mutated tumors. Actually not on this list, but something else is that there's 2 actually phase 3 trials of maintenance therapy for uterine cancer for advanced or recurrent that are P53 wild type that target the XPO1. So the first trial that was done with that was presented failed to meet its primary endpoint. However, they noticed that there was a huge difference between the P53 wild type versus the P53 mutant. And so they had allowed all comers in the first trial, and so they're basically redoing the trial. And I can't tell you what the data is, but it is pretty good in the wild type that get the drug. And so then there's a new agent, a second agent in that field as well. So those are trials if you don't have open, but you're curious about, like, especially say your MMRP. If you don't think that the data that we've shown from Ruby and GY018 is good enough, maybe those are good patients to put on that trial. All right, thanks everybody for your attention.